Good afternoon, everyone. Welcome to our webinar. Today, I think we are honored to have a distinguished speaker from Malaysia and also from Indonesia. I think each of them are very experienced and leading in their field. So I think we can learn a lot today. Especially our topic is concentrating on the heart failure. We started from the diagnosis, which is going to be presented by Dr. Aryo. Dr. Aryo is from Heartology Indonesia. Is also active in the Society of Echo in the region. And then we followed that with medical management, and also after medical management, it's going to be presented by Prof. David Chu, very well-known professor in the region. And also follow with that, we're going to have a revascularization treatment and also structural intervention to help patient with heart failure. It'll be presented with Dr. Chu. And lastly, we can have device management on heart failure. So it's quite a range spectrum of management, starting from diagnosis and then ends up with devices managing patient with heart failure. So the objective, of course, maybe after listening to this webinar, we expect all the audience will know what sort of option for what type of patients that can be given to patient with heart failure. With that, I think I'm gonna our speaker. First speaker, as you can see, is Dr. Aryo Kunchoro. His specialty is in imaging and concentrating in structural heart disease and also a heart failure program. And he's very well known in the cardiology field, especially for his imaging and also in the region. With that introduction, I think I'm going to let Dr. Aryo to start his presentation. And I think the floor is yours, Dr. Aryo. You have 15 minutes to enlighten us with the and workup patient with heart failure.
Yeah, okay, Dr. Doc, thank you for the introduction. So can you hear my voice clearly?
Yes, so, I can hear you clearly.
Okay. So yeah, thank you. So thank you everyone for joining us today webinar. So, and also I'm honored to be here with the other distinguished speakers from Malaysia and others from Indonesia. And I'm gonna be talking about the diagnosis workup and concentrating myself in this talk to the role of echocardiography in the front line in the clinic. So I will share my screen. So just bear with me for a second. Okay. So I hope you can all see the my slides here. Okay. So it's going to be a very brief talk of 15 minutes. So I hope I can cover everything in the right time. And the outline, my slides will be just a little bit briefly about the burden of heart failure in the community and the etiology of heart failure. And I will continue the diagnostic workup, the clinics and the hospitals, and the heart failure terminology and class, which is I think is also important to know or to learn more about the role of echo in the heart failure assessment. And also I will briefly talk about the echocardiography parameters in heart failure assessment. And then I'll wrap up everything, the talk. So well, we see this chart and we see that just want to show you that the heart failure is still one of the most common heart disease, which you are able to encounter in any part of the world. And the number seems to increase, especially in the developing countries like Indonesia, maybe also in Malaysia. And this, you can see that the heart failure is especially related to increase of age. The older the patients, the more prone of the patients to have a heart failure. And this is still a very common disease state we find in a part of the world, which I already mentioned. And this, we can see that the proportion of the heart failure could be occurred in men or women. And okay. And as I was speaking about the etiology of heart failure, so there are many etiology of heart failure. So the most common will be the coronary artery disease, as you're well aware of it. And then the other will be hypertension and or hypertensive heart disease and peripheral heart disease, and also cardiomyopathy. Less common, which is, but yeah, but worth mentioning, like arrhythmias, which probably other speakers will talk about this more, and the collagen heart disease, collagen vascular disease like SLE, metabolic disorders like diabetes mellitus and thyroid heart disease, and also myocarditis, pericarditis, and any form of inflammation disease to the myocardium. And other specific, such as like postpartum cardiomyopathy, is more specific part of the cardiomyopathy, which only after pregnancy, occur after pregnancy. So I point out here this echocardiography because the echo is one of the most easy tool that you can find in any hospital, any heart failure clinic in all over the world. Why? Because it is easy to use, and it does not require any preparations, and relatively cheap. And in terms of, if speak about the heart failure in ischemic heart disease, you can see that echo is able to pick up the first sign of the ischemia during resting or stress, with a segmental dysfunction, or maybe even the left ventricle systolic or diastolic dysfunction. And of course, the role of echo is really very important in terms of the peripheral heart disease, when the echo is able to see or to explore the structure of the valves and also the function of the valves. Okay. And speaking of the heart failure is basically a disease base of from symptoms and signs. So I wanted to bring this to us, to remind us that the diagnosis of the heart failure based on the symptoms and signs is sometimes not easy. So from the guidelines from societies, show us that we sometimes need to have a scoring system to see whether the patient has the probability for really having a heart failure. And you can use several other score out there. The left side is a clinical scoring system for acute heart failure, endorsed by the Canadian Society. And the right is the symptoms of the heart failure from, you can find it from the guideline from the ASC. And of course, we are also well aware that there are other clinical scoring, like from Framingham score, which help you to define the patient, whether the patient have a heart failure or not. And if you look up the diagnostic workup as the review, so when we have a patient with a suspected of heart failure, in the setting is a non-acute onset, so come to us to the clinics, then we have to, of course, we need to take the diagnosis and to treat promptly. We need to gather information from the clinical examination and simple examination such as EKG, which is basically is mandatory. And then if it is routinely conducted, so you can have a laboratory check, like such as a natriuretic peptide. But if you don't do that routinely in your clinic, so you can straight go to the echocardiography. This is the point where the echo is very important in this matters for the heart failure diagnosis, where because the echo able to detect the ventricular dimension dysfunction, abnormalities, and also dysfunction of the heart. And I already mentioned that echo is quite easy to access, and also is relatively cheap. And if we look at the guideline from the European, they put TTE, transthoracic echocardiography, as a class 1 for the assessment of myocardial structure and function in suspected heart failure to establish and diagnose of either heart failure with reduced ejection fraction, heart failure with and preserved ejection fraction, and also a gray area between reduced and preserved ejection fraction. This is also again stressing the importance of the echo in this setting. Okay, so I have already mentioned that there are terminology of heart failure and classification, which is important to point out that based of the ejection fraction, which is the parameters generated by the echo mostly, which is easy and it's been well known for quite a long time, that the ejection fraction used as a mean to differentiate patients with heart failure. So based on ejection fraction, so you can define patient as the reduced ejection fraction and preserved ejection fraction, and also with intermediate between reduced and preserved ejection fraction. All of these criteria classification, a patient has to have at least 1 or 2 symptoms and sign of heart failure, and then you look at the ejection fractions. But you can see here that from the table at the middle, so other than the ejection fraction, we have to collect also data about the BNP, elevated of natriuretic peptide if it is available, and at least one additional criteria, relevant structural heart disease, and also diastolic dysfunction. And this is another important parameters which echo will pick up, then able to define, so what is the classification of the diastolic function. And if we look at the grading or classifications of the or staging of the heart failure based on the European society, in the American society. So they classified the heart failure of A, B, C, and D, and those with the structural disease with signs and symptoms of heart failure is considered as stage C. Okay. So what possibly are the parameters that the echo can provide us in assessment for heart failure? Basically, the echo can help the heart failure assessment, which it able to comprise to at least 3 parts of assessment based on geometric assessment and hemodynamic and deformational or imaging or assessment. So geometric mostly deal with the dimensions, calculation of left ventricle functions from conversion of 2D or 3D indices such as ejection fraction, which I already mentioned, and others will be LV mass or for LV remodeling parameters. And hemodynamic will cover diastolic function, estimation of LV filling pressures or left atrial pressure. And while deformation or deformational imaging is a recent technique to evaluate LV systolic function as well as myocardial intrinsic functional properties, which also currently used in daily clinical practice, just to as a adjunct point for from the ejection fraction to define whether the patient heart failure or not, or look at the prognosis of heart failure patients. And so if we look again as the staging of the heart failure from A, B, and C, and D, so we already see that from stage C and D, those with already heart failure and with structural disease, but some with a sign and symptoms, maybe with a mild heart failure with subclinical myocardial dysfunction. This is the part where echo can actually help. And then this, we can see here, there's, if we look at the table here, with one column is a myocardial dysfunction with preserved ejection fraction. This is related to those with the heart failure with preserved ejection fraction, and some already enter the C and D stages with a reduced ejection fraction, both with alterations of changes in dimension, thickness, and LV mass. But you can see that there are other parameters where we can use, from where we can echo and provide to define the patient's prognosis and also the outcome. So ejection fraction is a very well-known parameters, as I have mentioned already, used in almost any studies evaluating LV function or systolic function. Every studies out there must have mentioned about the ejection fraction. So because this is considered as the sole parameters to define the systolic function. So I just want to show you that these are the big studies evaluate LV function as one of the endpoint or target of treatment. And almost all of these studies set cutoff points of 52 to 55% as normal LV functions. So below that number, so it consider a reduced ejection fraction or reduced LV systolic function. But from ECHO's point of view, so ejection fraction measurement is definitely not perfect. So currently major guidelines recommend the use of volumetric assessment or using 3D to replace TD assessment of ejection fraction. So, but of course it depends on the facility. If it's available, then the volumetric method using 3D is actually advisable or recommended. The echo is able to measure the diastolic dysfunction. It's just another point to consider when we think about heart failure with preserved ejection fraction, where the LV filling pressure assessment is one of strong point where echo can help and differentiate that heart failure class. Several parameters needed to be applied. So there's no one perfect parameters to define diastolic dysfunction class. And the right side algorithm is for echo evaluation where ejection fraction reduced or there is evidence of structural disease. And the four parameters used are the mix of hemodynamic evaluation, which you can see from E per E ratio wave, and dimension changes detection with left atrial volume index with the cutoff point of 36 mils per square meter. And sign of increased pulmonary artery pressure is the jump point where increased LV pressure is suspected in these matters. And other new parameters aside from ejection fraction is the deformation imaging, as I have mentioned earlier, or some call it strain imaging. Strain imaging is parameters of echo where echo can pick up and evaluate the pattern of myocardial layers activity during systolic and diastolic. And this is considered as more sensitive than ejection fraction. And the result of assessment are GLS, global longitudinal strain, GRS, global radiation strain, and global circumferential strain. The most robust parameters will be in the GLS, global longitudinal strain, which probably have a role in diagnosis of heart failure with preserved ejection fraction. And also, not forget to also mention that some part of the cardiomyopathy where have its own specific pattern, like amyloidosis, where a strain imaging can really help to differentiate whether this is amyloidosis or not. And another clinical utility of the strain imaging is in one among others is in ischemic heart disease, where it is able to measure or to look at the outcome and early identification on outcome of a patient with the non-ST elevation acute coronary syndrome, where the lower the strain of global longitudinal strain, then the outcome will be worse. And also is some cases with valvular heart disease, significant valvular heart disease such as aortic stenosis, those with significant aortic stenosis, but with the low GLS, with a cutoff point of less than negative 15%, is considered have worse outcome than those with a GLS of a higher number or higher value. And the echo also should be measured routinely of the the estimation or evaluation of pulmonary arterial systolic pressure, and also the function of right ventricle, which should be done routinely for any cases or suspected of heart failure. As you can see here from the recent guideline, uh, this is the way how to measure the pulmonary arterial systolic pressure and how to measure the right ventricle function using echocardiography. And I have to mention the assessment of mitral regurgitation in the term of patient of heart failure, because it's also very important, because we all know that those come with the heart failure sometimes primarily caused by the mitral regurgitation, but the mitral regurgitation occur because secondary to the left ventricle remodeling, and it is what we call secondary mitral regurgitation. As you can see here, there's the complete workup of the mitral regurgitation. If we encountered any, is to evaluate from the transthoracic echo to look at the etiology, and then we have to define whether this is primary or secondary or mixed in disease. So because it will decide what treatment that we should further go after this. And then we calculate the severity of this mitral regurgitation, no matter what the cause is. And then we look up the etiology and other comorbidities and risk assessment and so on. And then we have to decide treatment that we want to pursue. We could pursue for surgical treatment. Surgical treatment also, we can suggest for repair, replacement, also concomitantly with other procedures like CABG or other procedures. And also, don't forget also to mention that there's a option for transcatheter treatment like S2H mitral clip repair, and maybe like left atrial occlusions, which could be done concomitantly with these kind of procedures. And the role of echo in this matters is detection of MR, which is quite obvious, and structural evaluation, severity, and case selection for non-surgical procedures, and also for past procedural guidance and follow-up after procedures. The evaluation of mitral regurgitation is definitely complex and sometimes not easy to do from the echo, whether from transthoracic echocardiography or from transesophageal echocardiography. And generally, if you want to measure or to look at the mitral regurgitation or mitral valves, then usually we send the patient for the transesophageal echocardiography for a complete thorough examination. And this is from at the left side here. I just want to show you that the recent development seems like to suggest echo is able to measure the quantification of mitral regurgitation more detail using the 3D properties or 3D modalities, where it is able to classify the severity of mitral regurgitation more detailed. So this is the last part of my presentation. So we can see that the role of echo in the evaluation of heart failure patients is for defining whether the patient at the class of heart failure with reduced ejection fraction or those with a heart failure with preserved ejection fraction or in between. No matter what the modalities that we're using from the echo, we can see the structure, and we might be able to define the etiology, and also we can measure other properties or parameters as a prognostic factors for these particular patients. And then as a clinician and as also part of the heart failure team, so we will decide what kind of treatment which is more appropriate for the patients. So I think that's my talk. So I think this is just a brief presentation of the role of echo, also the workup of the heart failure during the diagnosis and the complete workup. I think that's all my talk. I return to Dr. Duff. Thank you for the time.
Okay, thank you, Dr. Aryo, for quite a comprehensive presentation regarding the use of echo in heart failure. Yeah, I haven't seen any question from the question box, but I think I have a few questions. In one of the slide, there is a mention of anti-proBNP for diagnostic, right? And
Yep.
we know anti-proBNP, of course, also as a diagnostic and also a prognostic. It has a diagnostic and prognostic value. You also mentioned that echo here has a diagnostic and also prognostic value. Can you enlighten us? What would be the advantage of echo examination over the anti-proBNP regarding the diagnostic of heart failure and also the prognostic value?
Okay, thank you. That's a very difficult question, but simple question, difficult question, Dr. Duff. Thank you. But yeah, okay. But if you look at the natriuretic peptide, this is it's evaluation or measurement of the level of natriuretic peptide in the heart or cardiac, despite what the cause of the increased level. So, but from the echocardiography, there are parameters which is more specific to look at the prognosis of the patients. Just for example, if we look at the patient with the ischemic heart disease, so one parameters that we look for the prognostic factors, it could be in the ejection fraction, could be in the diastolic dysfunction, diastolic function, the classification of diastolic function, and so on. And those where they have heart failure with preserved ejection fraction, I think there are quite a lot of studies trying to look at the, because this is normal ejection fraction, so we cannot use ejection fraction as a prognostic factors. So, but we can use strain deformation imaging to look up the prognostic factors more detailed. So I guess this is just examples of how the echo parameters able to evaluate the able to tell us the prognostic of the patients, and it is based on the etiology or based on the pathophysiology of the disease. I think I hope that's answer your question, Dr. Duff.
Okay, thank you. I guess we have quite a varied audience here. Most of them are GP. I guess for that reason, maybe you can have some, when do they, in terms of diagnostic, I think anti-proBNP you can use for diagnose heart failure. I guess to simplify the question, why would you need the echo if you can just diagnostic with anti-proBNP? I guess what sort of information will you gain, or when to send to echo?
When to send to echo? When
why do we need to send it to have an echo examination?
Yeah, because echo can give you a lot more than the natriuretic peptide. It's just like natriuretic. If you have an increased level of BNP, and then you conclude that okay, the patient has likelihood of heart failure, but you cannot explain to the patient what the etiology, the pathophysiology, and you cannot also explain the like treatment procedures and so on only based on BNP. So that is the important part of echo, which where echo is able to show us and explore more about the structure and also the function. So as a clinician, so we'll be able to explain to the patient so what the prompt treatment that the patient should have.
Great. So there's a question actually from the audience, which similar to my question, maybe just to put it briefly, the answer briefly. So when do we need to should have an echo examination done?
Okay, so in terms of heart failure, and you have suspected of heart failure, I think you have to have an echo exam. And that is transthoracic echo is a class 1 uh, uh, recommendation to for all patients with suspected of heart failure. Remember that even when we have the patient with the specific symptoms of the heart failure, but with a small heart, with from chest X-ray, maybe small heart, but just remember that there's part of these patients that could have heart failure with preserved ejection fractions, where the echo can actually help to tell clinicians whether this is the case or not. I think that's my brief answer. Yeah.
Okay, thank you, Dr. Ayut, and thank you, Dr. Puspa, for the question. So basically, if you suspect heart failure, you need to send the patient to have an echo examination for further evaluation on the etiology and the cause and the causes, and also what sort of treatment is appropriate for the corresponding patient. All right, I think we're gonna proceed to our next speaker. I think our next speaker is from Malaysia, Prof. David Chu, and he'll be presenting on the medical management of a patient with heart failure, concentrating on medical management. I think we are lucky here to have David Chu. He's quite a distinguished speaker. He's well known in the region for heart failure, and currently he's working in the concentrating in the CVSKL. So,
thank you, Dr.
Prof. David, please, the floor is yours.
Can you see my slide?
Yes.
Okay, so
Clear.
I'd like to welcome all the listeners from both Malaysia and Singapore to this joint webinar between CVSKL and Heartology. So I'm working in CVSKL in Kuala Lumpur, and I've been given the task of talking about medical therapy. So because the time is kind of short, I want to keep it simple. I just like to briefly comment about medical therapy of heart failure in general, and then focus specifically on management of chronic heart failure with reduced ejection fraction. For acute heart failure, there hasn't been much progress in treatment. We still use diuretics, usually intravenous diuretics. If the blood pressure is good, we use vasodilators. And if the patient has low blood pressure and poor cardiac output, we use IV inotropes. For the group of patients with heart failure with preserved ejection fraction, where the EF is more than 50%, many agents have been tried, but up to now, none has been shown to improve outcomes. There's been some interest in the use of a new group of drugs, which is the angiotensin receptor neprilysin inhibitor for the treatment of this condition. But unfortunately, the Paragon trial, which looked at this drug versus valsartan, showed that there was no significant benefit, even though there was some suggestion of benefit in subgroups. Most of the progress in the management of heart failure has been in heart failure with reduced ejection fraction, where the EF is below 40%. So these are some of the landmark trials that have taken place over the last 20 years, 20, 30 years in patients with heart failure with reduced ejection fraction. I'm not going to go through all these trials, except to tell you that basically these trials establish a few classes of agents that are useful in terms of a reduction in mortality, reduction in hospitalization, reduction in symptoms in patients with heart failure with reduced ejection fraction. I will select a few of these studies. ACE inhibitors were studied in the soft treatment arm. The CVS2, the MERIT-HF look at beta blockers. CHARM look at the use of angiotensin receptor blockers. SHIFT looked at the use of ivabradine in patients with heart failure with reduced ejection fraction. The emphasis looked at the use of eplerenone in patients with heart failure with reduced ejection fraction. Paradigm was active comparator where it compared sacubitril valsartan against enalapril. And I will touch a little bit more on these last two trials, which use the diabetic agent, dapagliflozin and empagliflozin, in patients with heart failure with reduced ejection fraction. This is quite recent, 2019, last year, and this was last month. The trial results were announced. So let's briefly review the first class of agents is the ACE inhibitor. This is one of the studies using ACE inhibitors in patients with heart failure with reduced ejection fraction. And it showed that when patients were treated with enalapril compared to placebo, there was a 16% reduction in all-cause mortality and a 26% reduction in all-cause mortality and heart failure hospitalizations in patients who used enalapril. So this established the use of ACE inhibitors in the treatment of heart failure with reduced ejection fraction. And then we have had a number of studies using different beta blockers, bisoprolol, carvedilol, and metoprolol. And quite similar reduction of all-cause mortality, about 34 to 35% with the use of beta blockers in chronic heart failure with reduced ejection fraction. So this established the role of the second class of agents, which is beta blockers in the treatment of heart failure. There was an earlier study called SGLT2i, which used the spironolactone in patients with severe heart failure, which showed a 30% reduction in all-cause mortality. This was another study using eplerenone. These are in patients with mild heart failure with reduced ejection fraction, and the primary endpoint was hospitalization for heart failure or cardiovascular death, and there was a 37% reduction in this event in patients who received eplerenone. There was also a 24% reduction in all-cause death in patients who received eplerenone. So this established the third class of agent for the treatment of heart failure with reduced ejection fraction, which is a mineralocorticoid receptor antagonist. Spironolactone is much cheaper than eplerenone, so it is usually preferred, but eplerenone has the advantage that it doesn't have hormonal side effects like gynecomastia. Then came along the paradigm heart failure, which looked at sacubitril/valsartan. Sacubitril/valsartan is actually a combined compound, which after it's ingested is broken up into separate sacubitril and valsartan. Valsartan is an angiotensin receptor blocker, so it blocks the angiotensin receptor and therefore blocks the renin-angiotensin-aldosterone pathway. Sacubitril blocks nephrilizin. Nephrilizin is an enzyme that breaks down natriuretic peptide. Natriuretic peptide has beneficial effects in heart failure, and if we can inhibit the breakdown of natriuretic peptides, more natriuretic peptides are available, and natriuretic peptide causes vasodilatation, reduces blood pressure, and increases natriuresis and diuresis. So we try to balance the vasoconstriction by inhibiting it and promote vasodilatation, and therefore try to improve heart failure. And this compound was studied in the paradigm heart failure. It was not against placebo, but compared with enalapril, which is the standard of care. And it showed that there was actually a 20% reduction in the primary endpoint of cardiovascular death or heart failure hospitalizations. So there was a significant benefit, and the trial was actually stopped early because of the superior benefit of sacubitril/valsartan against enalapril in patients with heart failure with reduced ejection fraction. Not only that, when you looked at the individual endpoints, cardiovascular death was reduced by 20% in patients who received sacubitril/valsartan. Heart failure hospitalizations was reduced by 21%, and all-cause mortality was reduced by 16%. All these three reductions were significant compared to enalapril. And then we have the fourth class of agents, which is the sodium glucose co-transporter 2 or SGLT2 inhibitors. So this class of agents was actually developed to treat diabetes. And how it works is that SGLT2 is present in the proximal tubule, And the function of SGLT2 is to absorb glucose back from the glomerular filtration so that less of it is excreted in the urine. There's also SGLT1, which also absorbs glucose. SGLT2 inhibitors block this compound and therefore inhibits the absorption of glucose. So glucose is lost in the urine. So that was the premise of the use of this class of agents. And in the EMPA-REG outcome trial, empagliflozin was studied to see whether it was safe cardiovascular-wise in patients with diabetes. And the surprising finding of the EMPA-REG outcome trial was that there was actually a significantly lower cardiovascular events in patients who received empagliflozin compared to placebo. And what was even more interesting was that there was a reduction, significant reduction in hospitalization for heart failure in patients who received empagliflozin in this study. Subsequently, other SGLT trials using canagliflozin and dapagliflozin also showed this same trend, that there was a reduction in cardiovascular death and heart failure hospitalizations, both in patients with cardiovascular disease as well as in patients without cardiovascular disease but with diabetes and other cardiovascular risk factors. A 24% reduction in the risk of CV death or hospitalizations in diabetics with established cardiovascular disease, a 16% risk reduction in patients with diabetes with just multiple risk factors. And when they look at the outcomes in terms of whether the patient had history of heart failure or no history of heart failure, there was a reduction of CV death and heart failure hospitalizations as well. So what is the possible mechanisms for the reduction in heart failure hospitalizations? It could be that when you inhibit the glucose absorption, you promote diuresis and you reduce body volume. But diuretics also does that. It could be also that you reduce afterload and blood pressure, because there is a slight drop in the blood pressure in patients who receive SGLT2. It could be there is a reduction in arterial stiffness. It also reduces renal afferent tone and sympathetic activation. So it may have some effect on the renin-angiotensin, aldosterone, and sympathetic system. It could also be because of metabolic effects, because with loss of sugar, loss of glucose, there's a switch to fatty acid metabolism, the use of ketones. And some people believe that there could be starvation mimicry. So it resets the body's metabolism. Whatever it is, the mechanism is still not too clear, but studies have actually been carried out with SGLT2 in patients with heart failure with reduced ejection fraction. The DAPA-HF study using dapagliflozin was presented in 2019, and it showed that in patients with heart failure with reduced ejection fraction, half of whom were diabetics and half were not diabetic, there was a reduction in the primary outcome of 26% in terms of CV death, heart failure hospitalizations, or urgent heart failure visits. And this has been repeated in another trial called the EMPA-REG trial using empagliflozin, where there was also a 25% reduction in the primary endpoint of cardiovascular death or heart failure hospitalizations. So I believe this would be the fourth class of agents to be used for the treatment of patients with heart failure. So if we were to summarize the pharmacological treatment of symptomatic heart failure, for mortality reduction, we should use ACE inhibitors. If the patient can't tolerate ACE inhibitors, you can use an angiotensin receptor blocker. Or if the patients are suitable, they should probably use angiotensin receptor neprilysin inhibitor, because this seems to be better than ACE inhibitors. Second class of agents would be beta blockers. The third class of agent would be mineralocorticoid receptor antagonists. And perhaps we should use sodium glucose cotransporter 2 inhibitors in patients with heart failure with reduced ejection fraction as well. And for symptom relief, diuretics like furosemide can be used, but if the patient has no volume overload, these medications is not that important. Digoxin and ivabradine can be used in patients for relief of symptoms to reduce hospitalizations. ivabradine in patients where the heart rate is above 70 and they are still in sinus rhythm. Now, if you look at the paper that was published in the Lancet, looking at if we use the modern therapies that are available, the use of angiotensin nephrolysin inhibitor, beta blocker, mineralocorticoid receptor antagonist, and SGLT2, and we compare with the conventional two drugs of ACE inhibitors and beta blockers, the use of these 4 agents versus 2, you will actually get an additional 62% reduction in cardiovascular death and heart failure hospitalizations, a 50% reduction in cardiovascular death, 68% reduction in heart failure hospitalizations, and about a 50% reduction in all-cause mortality. So we need to use the drugs that are available to try and improve outcomes in patients with heart failure with reduced ejection fraction. I also need to add that patients have other comorbidities that may require treatment. If they have high blood pressure, the use of antihypertensive is important. And in diabetics, it has already been in the guidelines that if diabetics have heart failure, they should be given SGLT2 inhibitors already. But I'm talking about the use of it also in non-diabetic patients. Now, if the patient has coronary artery disease, antiplatelet agents are useful to reduce the risk of myocardial infarction. Statins are also useful to prevent progression of coronary artery disease and reduce the risk of myocardial infarction. And if the patient has atrial fibrillation, anticoagulation, either with warfarin or new oral anticoagulants, would reduce the risk of stroke. So this is my last slide. Basically, what is highlighted in red are drugs that improve mortality. So ACE inhibitors, ARNI, beta blockers, or mineralocorticoid receptors, and perhaps SGLT2. But I think this is not yet accepted in the guidelines and not even a standard of care currently, but it's something for us to think about. Thank you very much for your attention. Back to Dafsa.
Sorry. Thank you very much, Prof. David. Excellent talk. We have, before we proceed to our next speaker, we have one question from the audience. Dr. Ratna, he is asking, can we use a beta blocker and ARNI in acute heart failure cases? Or is it only used in maintenance setting or chronic setting?
So in acute heart failure, I think the main thing we want to do is to stabilize the patient. So that would be using IV diuretics to remove fluid, vasodilators or inotropes. If the patient is a known case of heart failure and is already on the beta blockers, generally I would not stop the beta blocker. I will continue it unless the patient has low blood pressure, need inotropes, or the heart rate is slow. If the patient is not on the beta blocker, I would start it when the patient volume status has improved, meaning that the patient is no longer congested, no longer breathless. The use of ARNI in patients with heart failure has been studied in a trial called the Pioneer trial. And in this trial, after the patient has been stabilized, they can actually be started on angiotensin receptor nephrolysin inhibitor before they are discharged from the hospital. So that is actually an approach that can be considered for these patients. So I think use of ARNI is a reasonable step if it's available, if the patient has heart failure with reduced ejection fraction.
All right, thank you very much, Prof. Chu. There's one question I'd like to ask. In light of your, in one of your slides from Lancet, there's quite they compare the treatment of modifying factor medication in heart failure. If we use all the new drugs like the ARNI and eplerenone and also the SGLT, in your slides it shows that it actually reduced mortality by 50%. What is your practice in terms of managing patient with heart failure? Are you routinely using all those new drugs?
So I guess more and more we are using it. The only prohibition or things that make it difficult for us to use this drug is that they are new and therefore they are expensive. So if the patients have severe heart failure, then if the ejection fraction is very poor, then I would probably put them on all these drugs, probably not at the same time, but quite soon after starting. So they will probably get ARNI, they get a diuretic, they will get a beta blocker. I would use spironolactone, not eplerenone first. And if they're diabetic, I would probably start the SGLT2 inhibitor straight away. But if they're not diabetic, I might introduce it a little bit later. Because it comes later in terms of the trials as well.
All right, great. I think I'm going to continue for the question from one audience. Can we use SGLT2 in therapy patient without diabetes?
Yeah,
that's a question from the audience. Yeah.
So this is because of the two trials in the DAPA-HF and the EMPA-REG trial, where they used dapagliflozin and empagliflozin. They studied patients with heart failure with reduced ejection fraction, and in both these trials, about 50% of the patients in the trials were non-diabetic. And when they did subgroup analysis of the effects of the drug on these two trials, there was a reduction in the primary endpoint of cardiovascular death and heart failure hospitalizations in the non-diabetic subgroup as well. So yes, based on the evidence, these drugs can be used in non-diabetics to benefit them for heart failure. You will reduce cardiovascular death and heart failure hospitalizations in this patient using these drugs.
Great. I think with more experience and other study from registry, I think we can be more confident in using it. Okay, I think we're going to continue our talk. Thank you very much, Prof. David Chu. We're going to meet again at the end in the Q&A.
Okay.
Our next talk is from Dr. Chu. Dr. Chu is an interventional cardiologist. He's doing a complex intervention and also peripheral intervention, and also cardiac CT imaging. He's currently in the CVSKL, and no better person to talk about revascularization treatment and device treatment on the heart failure than Dr. Chu. So Dr. Chu, please.
Okay. Thank you, Dr.
Yours. Yeah.
Thank you. Can I get the host to allow me to start my video because they stopped my video sharing?
Okay.
Okay, got it. Thank you. Okay, hi. Selamat sore, ibu-ibu, bapak-bapak. Good afternoon, everyone. Glad to be able to meet you, at least virtually. I haven't been to Jakarta for a long time. So let me just put up my slides first and then we will start shortly. Okay, so this is a good follow-on to what David has spoken about. I think we need to highlight that whatever treatment that we talk about in terms of managing heart failure, medical therapy should be the baseline therapy. Right? So every patient should be well treated with optimized medical therapy as before you go on to other additional or adjunctive therapy. Now, in a very short 15 minutes, 20 minutes plus, I just want to try to emphasize again to define what we call ischemic cardiomyopathy and the prognosis associated with ischemic cardiomyopathy. Then some concept about the importance of looking for presence of ischemia and viability, And once we decided that the patient is suitable for revascularization, then we talk about what are the considerations to choose between a coronary bypass surgery and a percutaneous coronary intervention. And very briefly, we will talk also about what happens when the patients have no option at all for revascularization. To sort of complete the whole sort of mechanical sort of treatment for heart failure, I just want to add on a few points about the current availability of treatment options for some valvular structural heart problem. Now, we know that there are so many possible causes of heart failure, from toxic causes to rhythms and so on. But we're going to focus mainly on ischemia, which is the #1 cause of heart failure worldwide. And regardless of whatever the etiology, all will come to the same natural history whereby there is a progressive change in the cardiac shape function. We call it cardiac remodeling. And one of the most classical and well understood remodeling model is what happens after a patient gets a heart attack, myocardial infarction. So you see how, for example, there is an infarct of the apex of the ventricle. Over time, there will cause a cell death. There will be a very activity going on at the border zone as the heart tries to compensate for the loss of myocardium. There's apoptosis, there's inflammation, and so on. And all these kind of processes led to a change in the configuration of the left ventricle, which becomes gradually more and more dilated and sort of rounded rather than a sort of conical shape. And this kind of change in the morphology is actually correlated with worsening heart function. So you see that over time, as the heart failure progresses, the heart gets remodeled, gets bigger, gets weaker, and the patient's prognosis gets worse. So whatever treatment that we are going to talk about, whether medical or structural or electrical, if you are able to show there's some reversal of this remodeling of the heart, that might actually predict the possibility of patient's recovery or improvement. Now we're going to focus mainly on the few strategies like surgery or therapeutic device, and also, but most of the time will be spent about how to revascularize patients with the most common cause of heart failure, which is ischemic cardiomyopathy. Ischemic cardiomyopathy basically refers to when you have a problem with the heart function, which is related to coronary artery disease. It may or may not mean that the person has got a previous myocardial infarction, and it usually relates to the heart failure with reduced ejection fraction. Now, this is often seen when you have ischemic cardiomyopathy in patients with not a simple coronary artery disease, but multivessel disease, or they have significant loss of myocardium from a myocardial infarction. If you look at the different kinds of cardiomyopathy or causes of heart failure, maybe the best prognosis may be peripartum cardiomyopathy, whereby the pregnant mother gets better once you actually deliver the baby. Ischemic cardiomyopathy probably hence lies somewhere in the middle. There are some other cardiomyopathy like related to the oncology drugs and so on, which are actually even worse in terms of prognosis. And with ischemic heart disease, you may be stable, but once you develop heart failure on top of ischemic heart disease, the patient's mortality amplifies up to 5-fold. So that is a bad sign once an ischemic heart disease patient gets heart failure. And when we talk about heart failure, we know that they die usually either from worsening pump, that means worsening heart failure, or sudden cardiac death, usually due to ventricular arrhythmia. And we understand that whether this is heart failure with reduced ejection fraction or preserved ejection fraction, these are the two common mechanisms of death. And ischemia may modulate this because presence of ischemia can trigger an arrhythmia and worsen the heart function. So thereby, it is important to think about trying to ameliorate ischemia to improve the heart failure. Few key things then, when we talk about ischemia, ischemic heart disease and heart failure, we are usually referring to a large burden of ischemia. If you visualize the coronary anatomy, it's usually a multivessel disease or left main altogether. There may be also extensive loss of myocardium or non-viability. So there's this concept that you probably need to look at whether the heart muscle is still alive or not. You know that up to half or more of the patients with ischemic heart failure, you may think that the LV function may be very poor, but maybe at least half of them may still have a live myocardium. And these are the patients that if you can revascularize, is likely to lead to improvement in the cardiac function. There are many ways that we can sort of define the amount of viable myocardium. It can be by echocardiography, with nuclear perfusion scan, PET scan, and so on. These various tests have different sensitivity and specificity, but basically, if you find viability at that segment, it predicts that that segment will improve in the function when you revascularize them. And very clear from a lot of the observational papers before, that if there is no viability, medical therapy is as good as revascularization. But if you have viability, you revascularize the patient's mortality here is actually greatly reduced compared to leaving them alone on medical therapy. This STITCH trial, which we'll go into a little bit more detail in a short while, basically again shows that if you have viability, you have a better prognosis. If you have no viability, they are more likely to die. The only strange thing from the STITCH trial was that in these patients with heart failure, they are randomized to surgery against medical therapy. Whether or not there's viability, the outcome is no different if you put all of them to surgery. Of course, the trend is there even without viability or with viability that it may be helpful. So basically, there's no difference whether you look at viability or not. So there are a few ways of looking at this, but most of us still would like to look at presence of ischemia or viability, especially when the LV function is very, very poor, before deciding if the patient would be suitable for revascularization. If there's no viability, we leave them on medical therapy. But if you follow the STITCH trial, you will revascularize all the patients regardless, or you don't even want to check the presence of viability. So this STITCH trial basically randomized patients with low EF below 35%, comparing bypass surgery against medical therapy. And the theory is that which one is actually going to be better. So the primary outcome that looks at all-cause mortality shows a trend towards benefit with CABG, but that's not statistically significant. But then we understand that there's actually a lot of crossover in this trial. Up to 70% in the medical arm actually went on to have a bypass surgery. If you look at the secondary outcomes like cardiovascular death or hospitalization, there's definite benefit with CABG surgery. In fact, when they look at patients on on-treatment analysis, meaning patients who were excluded, those who jump over to CABG for the medical therapy arm, is actually a reduction of 30% in the mortality. So, but of course, the $1 million, not rupiah question is, if you can revascularize, do you choose PCI or do you choose CABG? There's always the questions that my colleagues or the patients ask me. So now then we have to ask, we have shown in the STITCH trial that CABG is useful for heart failure, ischemic heart failure. Can PCI do the same? Unfortunately, there's no direct data looking at this group of patients. We can only infer from data of multivessel disease revascularization, both from RCTs, registries, and anecdotal evidence. So we know that if you have multivessel disease, CABG is better than medical therapy. In a more contemporary analysis here from patients who were diagnosed with multivessel disease by CT scan, like 2-vessel, 3-vessel, they are going to benefit more in terms of mortality if you revascularize them regardless of the modality. But there are some analyses here that PCI is better than medical therapy when patients have multivessel disease. So maybe PCI is an option. What more today that you know with the available techniques, technology that we have, we can actually not just treat simple lesions, but even total occlusions like that can be revascularized beautifully. So many patients or even colleagues that ask about the builder, bolehkah kita bisa lakukan bubur ring? Of course bisa. But the problem is, the question should not be bisa ke tidak, but harus ke tidak kita langsungkan rawatan PCI. This is probably the Guinness World Book of record where this patient had 67 stents. So it's somewhat crazy sometimes. So much so that the patient or the media sometimes, they actually have a lot of kecurigaan that the doctors actually have have a motif kewangan. Yeah? So I think we should be more objective in how we choose the patient for other modality. We understand that not every patient is suitable for bypass or for angioplasty. For example, there are some patients with diffuse disease that there's no place that you can put a stent. You can't put it all over the place. And classically, you see that in diabetic patient. So let's briefly look at some data that guides us how to choose between PCI or bypass surgery. The Syntax trial basically look at patients with multivessel disease or left main, and up to 5 years if you compare with the first generation of drug-eluting stent against bypass surgery, basically no difference in all-cause mortality, although the trend is better for CABG. For cardiac mortality, CABG is actually better than first generation DES PCI. Every time you do comparison between CABG or PCI, PCI always do worse in terms of the need for repeat revascularization. You have an extended follow-up up to 10 years. Again, no statistically significant benefit in terms of mortality between bypass and PCI. But if you look at mortality in groups of patients with 3-vessel disease, CABG is still better than PCI. There are subsets of patients with multivessel disease with diabetes. This was tested in the FREEDOM trial. And in this trial, it shows that if you have multivessel disease and diabetes, CABG may be a better option for you. So after this trial, FREEDOM came out, they had a meta-analysis. And again, it was quite clear that diabetic patients with multivessel disease, CABG is better in a lot of the outcomes in terms of death, MI, but stroke may be increased in patients who undergo CABG. So the guidelines 2 years ago highlighted that if you have 3-vessel disease with a complex anatomy, this is a high Syntax score, CABG is better than PCI. If you have 3-vessel disease with diabetes, class 1 indication for CABG, not for PCI. So that is one consideration of how you choose. So there are data to guide us. There are some things that favor CABG, for example, if you look at poor LV function, diabetes, and so on. But there are some patients that cannot undergo CABG because comorbidities, COPD, and so on. So there are other factors that you need to consider. So I think instead of sort of battling or comparing between who should do it, a cardiologist or a surgeon, perhaps we should look at the objective data. But we also must remember that CABG and PCI are very different procedure in terms of complexity, in terms of the cosmetic result and the recovery of the patient. So we have to look at those scientific evidence, but also look at the available expertise locally. Now there is a concept of hospitals like Heartology and CVS. We have a team sort of effort where we come together and discuss what is best for the patient. This is called the Heart Team. But of course, the patients must be in the know and they are the ones to decide whether they want to go into the operation room or not. I just also want to highlight that those data that we talked about earlier were using first generation DES. There are some clues that with the newer generation devices that we use, they may be better. Here is comparing against medical therapy. Even in the New York State Cardiac Registry, when you use newer generation stents, there may be no difference in terms of death outcome, at least for the short, intermediate 4 to 5 years, more strokes for CABG. And even with diabetic patients, when you use the newer generation stents, they are quite equal, but once again, revascularization is worse with PCI. The other thing to consider is, very often, CABG will do a better job to do a complete revascularization. PCI, you are a bit limited because some vessels cannot be revascularized. So if you have a poor or incomplete revascularization, you have a poorer survival compared to complete revascularization. You also have less, you have more spontaneous MI if you do an incomplete revascularization compared to a complete revascularization. So from this New York State Registry, although we know that CABG has less spontaneous MI, but if you are able to perform complete revascularization using the new generation stents, actually there's no difference. So the other thing to consider is if you want to do a good job with PCI, it has to be complete as possible revascularization. And that's also highlighted in the guidelines as well. Quickly, I'll just share one case of a gentleman, 78 years old, with a multivessel disease, end-stage renal failure, recurrent admissions for heart failure, Ischemic Cardiomyopathy. This was his echo in February. He was admitted at the time with acute pulmonary edema. Look at the ejection fraction, it's really, really poor, 25 to 30%. And you see the dilatation of the LV, moderate mitral regurgitation. And this patient, because he was unstable, went for emergency care. Some of you will realize, you see that there's a balloon pump. These are supportive devices to support the patient during the procedure. So long disease in the LAD, there's some disease severe at the ostium or the circumflex. Long disease in the LAD here. And there's some right vessel disease as well, but we actually treated that. I'll show you shortly. So complex multivessel PCI from the left main all the way to the LAD. Treatment also in the bifurcation, the ramus. There's actually a aneurysm here with a decent result angiographically. On the right-hand side, also there's a long disease in the proximal mid-segment and treated. And this patient, 3 to 4 months later, LV function has improved, LV size has reduced, the mitral regurgitation has reduced, showing the potential for us to reverse some of this remodeling and improve the patient's heart function by revascularization. But sometimes patients have no option. You just can't do it because there's too extensive disease, too many comorbidities, cardiac transplantation. But unfortunately, cardiac transplantation is only available to the very few. There are not many donors available. In the past, we sometimes have to put what we call devices to assist the LV function while the patient waits for bypass surgery. But because there's so few donor or heart available, many times these kind of assist devices have become what we call the destination or the final therapy for the patient. So this has improved a lot from the first sort of LV assist devices in 1966. This was the first patient, to now there are so many other iterations of the devices. So very often in many centers, these have become the sort of end treatment for patients with no other options. Okay. Now, let's now move very briefly to the other kinds of heart failure that's due to a structural problem arising from the heart, from the valve. Aortic stenosis is really the most common acquired valve disease in the modern world today. It is degenerative because of progressive thickening and calcification of the valve. And by the time they manifest symptoms, they can present with angina, syncope, or heart failure. But by the time they get to heart failure, it means usually end or late stage, whereby they will not survive the next 1 or 2 years. The mortality is up to 50%. The standard of care has always been for surgery, because once the patient becomes symptomatic, their survival drops very fast. So standard of care has been to change the aortic valve. But because this disease very often happens in the elderly with many comorbidities, they do not get the standard of care because the risk of surgery is too high. That is why there was a development of a percutaneous option for the transaortic valve. The first case was 2002, and we have progressed so much today that there's so many patients are being treated with TAVR. This was the first procedure that's been done by Dr. Alan Crebier. There are a few designs, or mainly 2 designs available, and we found that this kind of percutaneous option actually is better than medical therapy in patients with no surgical option. In high-risk patients, they are as good as surgical therapy, and more trials are showing that they may be an option for lower surgical risk patients for a percutaneous aortic valve replacement. So this is a patient that we did 2 weeks ago, a 92-year-old lady with severe degenerative AS and class 3 heart failure with excellent results. So she's gone home about 5 days after the procedure. The next one is mitral valve. Mitral regurgitation can happen because of dilatation of the left ventricle, so you have a functional MR, or because of structural problem of the valve, because of mitral valve prolapse or problem with the chordae or the leaflet. There is a system called a mitral clip whereby you can actually try percutaneously to grab the 2 leaflets together, and so that you can oppose them and reduce the regurgitation. And so this is the mitral clip concept. Again, this so-called innovative treatment is now proven evidence-wise. There's a clip here that you have improvement in patients' heart failure hospitalization up to 3 years, with also improvement in mortality. So, ladies and gentlemen, friends, ischemic cardiomyopathy is still the most common cause of heart failure worldwide. When you have extensive ischemia, especially with presence of multivessel disease, there is a survival benefit if you revascularize them. What do you choose, whether PCI or CABG? There are a lot of things that you think about based on the evidence, extent of disease, heart function, diabetic status, comorbidities. Of course, you must remember about the collective team decision by the heart team, as well as the patient preference. Today, with newer generation devices to perform PCI and to be able to perform a more complete revascularization, we perhaps can narrow the gap of difference between CABG and PCI results. Even when revascularization is not an option, there are support devices for the ventricle, and cardiac transplantation may be an option as well. There are structural heart disease conditions, especially the valves, that has gone very far in terms of our options of treatment, like the aortic valve and mitral, and these are also to be considered beyond surgical therapy. Terima kasih. Thank you.
Thank you, Dr. Chu.
Yes,
thank you, Dr. Chu. I quite enjoyed that presentation.
Thank you.
It's quite thorough. We haven't had any questions, but maybe I like one question I like to ask in regards of mitral clip. When do you usually use mitral clip instead of mitral valve repair or replacement?
I think largely because of the availability of expertise, and as well as the cost of this procedure, patients are still, I think, referred to the standard of care, which is surgery first. We know that some of the mitral valve pathologies, like mitral valve prolapse and ruptured chordae, those do very well with surgery. If they are amenable to surgery, we have very good data with the long-term good durable results. So these only the patients where I think we think that there is a high surgical risk, and the surgeons again a heart team sort of concept feels that the surgical risk is too high, then the idea of mitral clip is actually brought into discussion. In Malaysia, we are sort of going into mitral clip. There are only one established center, which is the National Heart, that does it. In CVSKL, we are going to do our first case in 2 weeks' time with one of our colleagues who are from IGN. So we're really looking forward. I think there will be a lot of opportunities in the future, but it's just that it just opens up the possibility for the patients. Those who cannot have surgery, this is actually another option for them. So I think just increasing the options, improving the benefits for our patients.
Great. And also, I think most of the benefit comes from the degenerative type of MR, isn't it?
Yeah.
Okay, I think we need, in interest of time, we're gonna proceed to our next speaker.
Last speaker.
A colleague of mine, Dr. Diki, is quite well known in his field in the interventional cardiologist and especially interventional electrophysiologist. And his topic will be the device treatment in heart failure. Okay, Dr. Diki, please proceed with your presentation.
Thank you. Can the host enable my video? Okay, thank you. Okay, thank you, Dr. Dafsa, for the nice introduction. I would like to share my slides. Okay, here we go. Okay, can you see my slide? Okay, great. Well, Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera bagi kita semua. And good afternoon, everybody here. Well, after we have this talk about medical therapy, about diagnosis at first by Dr. Aryo, and then the medical therapy by Dr. David, and then the mechanical and vascularization therapy for heart failure by Dr. Chu. Now I would like to talk about the electrical therapy in heart failure. So it is all comprehensive in heart failure that we can all learn together. So one thing that we can do for patients with heart failure is the cardiac resynchronization therapy. But the problem is there are only a limited number of patients who maybe have a good response for this therapy. As we know that the cardiac output in heart failure is reduced. Yeah, it was already discussed before. And the ejection fraction is one thing that is usually reduced in patients with heart failure. Yeah. Okay, the heart failure classification, as we all know, we use the New York Heart Association classification with class 1 where there's almost no symptoms, and then the class 2 with mild symptoms, occasionally swelling, somewhat limited inability to exercise, and then there's the more severe symptoms with noticeable limitation, ability to exercise or participate in mildly strenuous activities, and there's the class 4 where the patients are unable to do any physical activity without discomfort or there are symptoms at rest. So the electrical therapy in heart failure focuses on the cardiac conduction. Well, of course, you can say that electrical problem doesn't necessarily translate into mechanical problem or vice versa, that mechanical doesn't translate into an electrical problem. But in heart failure, there's a problem usually due to intraventricular electrical and mechanical problem, and the interventricular mechanical, which also sometimes translates into the electrical delay. Heart failure, of course, the prevalence is increasing, especially in older adults, and incidence is quite high, about 500,000 new cases each year, and the morbidity is more than 1 million heart failure hospitalization in the US alone, which causes and contributes to more than 600,000 deaths per year in the US, and 50% of these patients die suddenly. So even though these patients have already optimal medical therapy and have been revascularized, the survival is still reduced. If you can see, 80% and 70% of 80% of men and 70% of women who have congestive heart failure will probably die within 8 years. And there are clinical challenges in heart failure. The hospitalization increases more and more after the primary diagnosis of heart failure, and repeated heart failure hospitalization are associated with increased mortality. Of course, the financial burden of heart failure is also quite high, which especially the repeated hospitalization drive the healthcare costs. And this impacts on the healthcare. And the average length of stay is up to 5 days in most patients with heart failure. So what can we change? Of course, medical therapy is the cornerstone in heart failure management. Revascularization, mechanical therapy is possible, but of course there's another one which is called the electrical therapy. In terms of most heart failure, not most, but some heart failure patients have a dysynchrony when they get the dysfunction of the ventricle. If you can see on the left side here, there's a good contraction of all the walls of the left ventricle here. Yeah, you can see my pointer. But on the right side here, you can see that there is somehow undulation of the left ventricle with desynchronized contraction of the lateral and the septal wall. So they do not contract simultaneously. This is called desynchrony. So, and ventricular dyssynchrony, if we find this ventricular dyssynchrony, we can correct it with the cardiac resynchronization therapy. This is a kind of pacemaker which can try to correct the electrical dyssynchrony. Usually, the electrical inter or interventricular conduction delays, which is typically manifested as left bundle branch block, and there's a disruption of myocardial collagen-metric impairing electrical conduction and mechanical efficiency. So this is the electrical left bundle branch block. Usually we can correct this with cardiac resynchronization, where we can try to improve the electrical conduction, which then translate into improve of mechanical contraction. That's why it is also called a biventricular pacing. So we can see here, this is where there's dysynchrony. You can see clear contraction, dysynchrony with increased QRS duration of 180 milliseconds. And then we can put in a left ventricular lead here in the coronary sinus veins. And when we can do simultaneous pacing, so the QRS duration would narrow and the contraction would become more efficient. But what are the evidence? There's a lot of evidence that CRT is highly beneficial. Since the year 2000, there are a lot of randomized controlled trials which shows CRT extends survival, reduces heart failure and hospitalizations, improves cardiac function, and improves functional capacity or quality of life. More than 7,000 patients were studied. That's why the guidelines also recommend the CRT in patients with a ejection fraction less than 35% in sinus rhythm and a left bundle branch block with a QRS duration of over 150 milliseconds with a functional class 2, 3, or ambulatory class 4, and already under guideline directed medical therapy, CRT has a class 1 recommendation. Of course, it is also recommended in less severe QRS duration, but it is only a 2A recommendation as long as it is still in left bundle branch block or in a non-left bundle branch block with a QRS duration of over 150. Of course, the Indonesian guidelines for our Indonesian colleagues here, we already have our cardiac implant electronic device therapy guideline, which can be where I was the chair. We have produced this guideline of 2014. Unfortunately, we did not have the time to make a more revision with the current data, but it's still you can download this, of course, at inahrs.or.id to read about the recommendation. So CRT reduces heart failure admissions across CRT indicated patients populations, and 1 year after implantation, there's a 53 reduction in heart failure admissions and 52 reduction in heart failure admissions in class 3 or class 4 patients, functional class patients. But what are the constraints? The constraints is, of course, the cost, especially here in Indonesia, but the healthcare provider, all of them, most of them are already covering CRT. Of course, there's a patient selection of the patients with a wider QRS are more, have a better response to CRT, especially in left bundle branch patients, and the awareness that we have this type of therapy option for patients with electrical dysynchrony. For our Indonesian colleagues, singkat cerita, apa itu CRT? Terapi untuk mengatasi konsekuensi mekanik dari disinkroni konduksi jantung dicapai dengan pacuan biventrikel yang sinkron dengan atrial untuk memulihkan sinkroni AV dan ventrikuler serta meningkatkan efisiensi pompa jantung. Sebagai tambahan terapi dari terapi medikamentosa. So, all on top optimal medical therapy. And of course, sudden cardiac death, a little about ICDs as an electrical therapy in patients who do not get into the criteria for CRT. There is a relationship between sudden cardiac death and LV dysfunction, which is the ejection fraction is the single most important risk factor for overall mortality and sudden cardiac death, and it increases risk immeasurable at ejection fraction above 30%, but an ejection fraction equal to or less than 30% is the single most powerful independent predictor for sudden cardiac death. You can see below 30% of ejection fraction, the percent of sudden cardiac death is 7.5, which is the most important risk stratifier. And of course, in the functional class 2, sudden cardiac death is the prominent cause of death, up to 64%, but in the functional class 4, it is the pump failure, the prominent cause of death. So there are a lot of studies showing evidence of heart failure and sudden cardiac death risk, the SCATEF and the MEDI2, which shows that ICD, implantable cardiac defibrillator, can prevent death, especially in functional class 1 with an ejection fraction of less than 30%, or functional class 2 or 3 with an ejection fraction less than 35%. The ICD is a class 1 indication. Okay, that's all from me. Any questions? Thank you all for the attention. I think I made good time, 15 minutes, right, Dr. Dapsa?
Great. Thank you very much, Dr. Diki. Okay, I think we haven't have any question from the attendees or the participants. I'd like to ask a question regarding the CRT. Maybe all the other panelists should join in, and so we can have some sort of discussion. When would you suggest should we refer a patient for CRT consideration?
Well, of course, medical therapy is still the cornerstone in heart failure patients, and revascularization, especially if it is a ischemic cause of heart failure, revascularization has to be optimized. And after that, then we see if the patient has a sign of dysynchrony, which is usually seen in the EKG as a left bundle branch block conduction, or a wide QRS of over 150 milliseconds if it is a non-left bundle branch block. So if the patient has an ejection fraction less than 35%, a wide QRS, then is still symptomatic, at least functional class 2, then a CRT should be considered in these patients. It increases survival, it increases quality of life, yeah. On top of the optimal medical therapy and the revascularization, of course.
Dicky,
Okay.
may I take
Great.
on what you
Yes.
just mentioned now? What about ICD? Very often we have to revascularize patients with ischemic cardiomyopathy, and we think that with the EF, if it's too low, we might want to consider an ICD. How long do you think we should wait to see recovery of LV function before to say that maybe this person deserves an ICD?
Well, yes, of course, at least 1 month or 30 days, we need to wait. That's the minimum that I would wait to see if the revascularization that we did has improved the ejection fraction. But usually we can actually see due to the scar that even if we revascularize maximally due to the scar, usually the ejection fraction, if this is already a very, very low ejection fraction or LV dysfunction, very severe LV dysfunction, then probably we shouldn't really wait, because there's still risk of sudden cardiac death in the very severe LV dysfunction. If this is a patient where the ejection fraction is only slightly even 3 months to wait is probably still okay. Yeah, especially if we see there's not much scar in the echo or the MRI or in the scintigraphy that we may.
Can we?
Connection not so good, Dicky.
Okay. Dicky, are you still there? Okay, maybe Prof. Chu, do you have a added comment on regarding on when do you usually send your patient for CRT consideration?
So I think the best response would be if the patient has symptomatic heart failure with EF that is below 35%, in sinus rhythm, and with a QRS duration more than 150 milliseconds, and not due to ischemic heart disease. But I think the response in patients with previous myocardial infarction.
Sorry, I lost you there.
Yeah.
My internet here is not stable.
Okay. Please continue, Prof. Chu.
Yeah. So if the patient has dilated cardiomyopathy, they respond better to CRT compared to ischemic cardiomyopathy.
Okay. Maybe in terms of echo, I'd like to have Dr. Aryo comments regarding because earlier I think Dr. Dicky mentioned there will be some would respond and some also non-responder. So in terms of echo, do you have any added comment, Dr. Aryo?
Yeah, thank you. So there's always questions for those candidates for CRT, so whether patients will be responder or not responder, right? So I think in terms of echo, so I think nowadays or recently, currently based on the guideline, so I think not many electrophysiologists send patients candidate for CRT for echo assessment before the CRT procedures, because the evidence say, as Dr. Dicky mentioned, that from the guidelines, it's just ejection fraction less than 35%, and then with a PRS, wide KRS complex. So the echo assessments maybe not really that beneficial in that sense. But yes, you're right. There are parameters from the echo which able to predict which case, which patient will be responder or not. So I think, and also in that sense, echo can guide the electrophysiologist to where to put the lead to the most less infected area. So I think that is one benefit that echo can give to increase the responders for CRT. I think that's my comment.
Okay. I think Dr. Ricky will
And
see there.
Yeah, sorry about that. I would like to give also a comment about echo in patients with ICD. So if we do, coming back to the questions of Dr. Chu, if we see in echo that there's a lot of scars already, even though we are trying to attempt a revascularization, of course, we do not need to wait for 3 months or 30 days to put in an ICD. If we in echo already see, okay, the prognosis here, even though we try to do a revascularization and this is almost all scar, probably then an ICD should be put in sooner or even directly, so to reduce the risk of sudden death during the time the patient improves the LV function. So although the recommendations all encourage to wait, but it's up to clinician actually if we really want to wait or not. So if we see this is high risk and from the echo we can see there's a scar everywhere, even with the best revascularization attempt, most of the scar will still be there. It will only be reducing the symptoms or slight increase in improve of ejection fraction, then ICD should be put in earlier.
Okay, I guess we still have 10 minutes. Maybe I'd like to discuss regarding the use of matter clip from all of you, especially as we know when we have a heart failure, there's the patient left ventricular become dilated and we have regurgitation. So, well, in regards to that, when would you consider patient for surgery or conservative or mitral clip or edge-to-edge correction? Maybe we can start with Dr. Chu or Dr. Aryo.
Aryo, do you want to go first? But basically, I think we must understand that the severe mitral regurgitation has got a few levels of pathology. It could be the valve, it could be the myocardium, it could be the annulus. So if it's because of the dilatation of the annulus, sometimes it's too large. You might not be able to do a good edge-to-edge sort of a position. So you got to consider annuloplasty for this kind of patients. So there's some consideration that if it's too large, maybe surgery would have been a better option to address the annulus as well as the valve pathology.
Would you like to add to that, Dr. Aryo?
Yeah, I agree with the Joe that there is the echo is able to select which the best candidate for mitral clips or not. So again, we have to look at the structure of the mitral itself, and we look at the pathology, whether it is a primary or whether it is secondary, and we have to if this is a primary pathology of mitral regurgitations and usually due to prolapse or flail, and then we need to measure the flail gap or flail width, and then we consider that where the basically when the flail width or flail gap is too much, it's more than 15 millimeters, and then we consider that this is that the patients might be not really a good candidate for a successful mitral clip procedures, and in those cases where the mitral regurgitations due to the secondary pathology, so we need to consider measuring the coaptation gap, coaptation length, and coaptation depth, to look at the successful rate of mitral clip procedures?
Great. So it's quite limited by the length of the clip, huh? And that's why the echo becomes very, very important in deciding which therapy we're gonna use for this kind of patient.
I have a question to Dr. Chu.
Yeah, go ahead.
So do you have an age constraint for mitral clip? How young, what is the youngest patient that you would do a mitral clip if all the parameters are aligned for mitral clip, that you can know you can do this? But would you do in all patients, or would you still send younger patients to surgery?
Well, I have to admit that I have very limited experience. We have not done one yet at this center. So it's actually, we are embarking on this new therapy. I mean, Fazil, you will know Fazil. He's gonna be our main guy who's going to lead us in this mitral clip procedure. So I think I won't be able to answer that. You guys probably know better than me in terms of the age requirement for this.
All right.
David, do you have any idea in your previous experience in IJN?
So I think there are basically mitral clip was developed actually for patients with severe MR whom the surgeons turned down because they're too high risk.
Yeah.
So that was the initial indication. So it was mainly for degenerative valve disease at the beginning. With the COAP trial showing that it's beneficial in functional MR. So these are patients that surgeons do not like to operate because the patient has heart failure, so that ventricle is very dilated and they have severe MR. But the patients in this group actually have MR which is probably a little bit out of proportion to the severity of the heart failure. So meaning that there is also a mechanical component. So it's probably this group that maybe benefits the most. I think age is probably not so much of a criteria. I mean, the patient usually, if they are younger and they are fitter, they might be better as surgical candidates. So the ones that are higher risk, that have functional MR, where the MR is very severe, and trying to treat the valve without having to send them to surgery, may be the candidates for the mitral clip.
Okay, great. Thank you, Prof. Chu. I think I'd like to flash back to the first question during our webinar, which I think the question was, there's two questions. One of them is already answered by Dr. Chu, but I think it's good that if we can share it again through live. The question is it true when patients have stent or ring that they are not allowed to do sport anymore? Because I think this is quite a general, not general understanding, most in non-medicine society, people who are not in medical, there is a view that once you get a stent, that means you are actually, what do you call it? You cannot do any more activities.
Invalid.
Yeah. Okay, maybe we can start with Dr. Chu, Prof. Chu, or David. I mean, I don't know how to pronounce this. Sounds similar.
Yeah. So I think generally there's no contraindications to exercising if the patient has a stent or ring. You have actually improved the blood flow, so the patients should have no more ischemia or reduction in ischemia. So they should be able to exercise. So maybe if you're worried at the beginning for the first week or so, you probably don't want them to exercise too vigorously. But after that, I think they should be able to go back to their normal activities. After the purpose of revascularization is to improve symptoms and quality of life.
Okay. Would you like to add to that, Dr. Chu?
Yeah, so I agree. I think that it's just we get this very often from our patient. The wife say, you just had a ring, so you cannot do this, you cannot do that, you cannot play sports anymore. But as David has said very correctly, that actually most stable patients, if the LV function is normal, there's no contraindication. We in fact encourage them to be more active in their physical exercises. The situation may be slightly different in patients who just had a STEMI, and then we might want to sort of be more graduated in their return to physical activity. And if you have a cardiac rehabilitation program, that will be a guided way for them to return back to the intensity of their physical activity before. And also, even if they have heart failure, we know that regular physical activity exercise actually improves the outcome in patients with heart failure. So that should be encouraged as well.
Okay, anybody would like to add to that? Yeah, I think it's already quite comprehensive. It's all depends on what setting is the stent or the ring is put in. Is it an elective case or acute? If it's in acute, of course, we also like to stratify whether it has damage causing heart failure in that patient. And if it's a patient in heart failure, of course, they still need to do exercise, but maybe there will be a rehabilitation for that, or the exercise should be doses. And the other question is, if the patient get a pacemaker, do they have to control regularly? That's the question from Dr. Nadia. Maybe Dr. Diki would like to answer that.
Yes, especially patients with CRT pacemaker, yeah, or especially the CRT pacemaker, because due to specific programming of the CRT, we need to see these patients regularly and check for maybe how we can improve the sequence of pacing between the left and right ventricle. For other patients like ICD patients or conventional pacemakers, 6 months follow-up, up to 1 year follow-up is, especially if they are in a remote area and they have no symptoms, then it is possible just to do a 6 months follow-up. But for CRT, 3 months follow-up is encouraged to do that, so we can change the settings of the pacing sequence when we see changes of the LV function itself.
Okay, great. I think we are right at the end of time, and before I thank everyone, I'd like to make a summary of our webinar today. So first, in the first talk, I think we highlighted the importance of echo, not only for diagnostic tool and also prognostic, and also give us an information on which device to select to improve the patient outcome. And then for medical management, can see that there is the foundation of the heart failure management and medication that works in renin RAS system, and also sympathetic system is the class 1 indication. And the new medication that came about in the last five years, such as nephrilicin, Perenon, and also the SGLT medication. It's actually, if we combine, we can have a clinical and also mortality benefit. But however, because there's still a new medication, the cost would be quite steep. So that's things that we can consider. And then as for the second talk, the third talk, regarding ischemic and regarding revascularization in patient heart failure I think Dr. Chu already demonstrated that ischemia actually worsen the patient outcome. So it's very important to do a revascularization, be it surgery or PCI. But I think the most important thing is when revascularization is done for heart failure, it should be a complete revascularization. And then the decision between PCI and CABG, I think it should be done in the heart team, and also looking into the experience of the center in doing a complete procedure and also surgery. And for the last part, I think it's regarding the CRT. We have CRT is one of the management in heart failure, especially in reduced ejection fraction with wide KRS. And the other thing is the role of ICD in patient who's already in not ischemic and have a relative quite a big amount of scar in their heart. I guess with that, we like to thank everyone in the participant for listening. I hope with this talk you've learned a lot and gained some insight on how to better manage patients with heart failure, and also all the various options that the heart failure patient can have to improve their clinical outcome and having a mortality benefit. And I also like to give a special thanks to Dr. Chu for joining with us, and also Prof. David for joining with us, and Dr. Aryo and Dr. Dicky. And with that, I close this session, and thank you everyone. It's been having a webinar with you, and I've also learned a lot. Thank you. Bye-bye.
Bye-bye.
Everyone, thank you. Terima kasih.